actually really excited to talk about sleep with all of you. As Helen mentioned, my particular areas of interest are helping people with complex medical and psychiatric comorbidities improve their sleep. And as always, that requires adaptation. And in fact, for those of you who missed it, I changed the title of my talk at the last minute from how to understand and manage the 6 dimensions of sleep health to this newest version, sleep is a 24-hour phenomenon, because as I was going through the various things I would tell my patients to help them improve their sleep, I realized almost everything I would say is going to require some sort of adaptation to help the folks you work with in palliative care. And so to me, conceptualizing sleep as this 24-hour phenomenon made more sense, because as I was saying to Helen, sleep itself is a totally passive process. We cannot force sleep. And in fact, the harder we try to make sleep happen, the longer we're going to be awake. So we can't put effort into sleep itself, but we can certainly put effort into what we do when we're awake in the morning, during the day, in the evening, that will increase the likelihood that we can get a decent night's sleep. And so that's what I want to focus my talk on. I forgot to put, I have no disclosures, conflicts of interest. I usually have a slide there, but apparently I forgot it. I also want to emphasize that my area of expertise is called behavioral sleep medicine. A subset of this is cognitive behavioral therapy for insomnia. But this is a nice definition of behavioral sleep medicine offered by the Society of Behavioral Sleep Medicine. So I focus, behavioral sleep medicine specialists focus on the evaluation and treatment of sleep and circadian disorders by addressing behavioral, psychological, physiological, familial, and sociocultural factors that interfere with sleep. So it's a very broad umbrella. There are a lot of sleep disorders and other things we address under behavioral sleep medicine, but I at least wanted to familiarize people with this area. I'm not going to tell you anything here that you don't already know, probably better than I do. So sleep in palliative care populations, not surprisingly, poor sleep is common. Whether people are receiving palliative care in the hospital or in the community, sleep disturbance does seem to be more common in individuals with cancer, and it is also more strongly associated with distress around pain, fatigue, and breathing difficulties. I think what struck me when I was looking at this particular study, this is a very big study, a prospective national cohort study of Australians in palliative care, over 100,000 people. What struck me about this is when I typically see someone with insomnia, there's a huge anxiety component. There are a lot of misconceptions about sleep, a lot of anxiety around sleep itself, the ability to sleep. For folks in palliative care, it is not so much the psychological factors that are disrupting sleep, but the physical factors. So again, there's pain, there's fatigue, there's breathlessness, there's GI symptoms. We'll talk a bit more about that for the next study. But of course, not surprisingly, if someone's sleep is disturbed, whether for psychological or physical reasons or both, it's going to negatively affect physical health, cognitive functioning, emotional well-being, and it can exacerbate a lot of other conditions in a palliative care population. Probably the most relevant are pain, fatigue, GI symptoms, delirium. And I think the special concern about this negative impact of poor sleep on various aspects of functioning is end-of-life care really requires a lot of complex decision-making, navigation around relationships, which can be in a somewhat, it's a very fraught place from which to navigate them at end of life. And so you want to ideally make sure that someone's emotional well-being, cognitive functioning, physical health is as optimal as it can be. And getting better sleep could certainly be part of this picture. This was a smaller study that was done looking at about 55 people in the community. Now, these were folks with cancer receiving palliative care. And this group was looking at the correlates of sleep disturbance. And again, as I've been mentioning, what they found is that there was more correlation between sleep disturbance and physical symptoms. So higher levels of reported pain, gastrointestinal symptoms, anxiety, depression symptoms. This was the case for both subjective measures of sleep. In this case, they used the Insomnia Severity Index, which is a very face-valid 7-item, widely used measure of insomnia symptoms, but also the correlates held with objective measures of sleep, like actigraphy. I think what's interesting, though, when we look at behaviors, more disturbed sleep subjectively was associated with lower light exposure over the 24-hour period and a more noisy environment at night. And we will certainly talk about both of those things. On the objective level, it was associated with more maladaptive sleep behaviors, meaning going to bed not when you're sleepy, but maybe when you're tired. So not waiting until you're sleepy to go to bed. Lingering in bed in the morning rather than getting up. We'll talk about the drawbacks of both of those things. And then more frequent napping was associated with higher levels of reported pain, fatigue, depression, and daytime sleepiness. I think one of the challenges, and I'd love to hear more from you all as I end the talk, but I think one of the challenges of working with the folks with whom you do work is there is such significant sleep disruption caused by these other conditions, the pain, the fatigue, the GI symptoms, and that's a different animal than straightforward insomnia. It's not just anxiety about sleep. Sleep is absolutely being disrupted by these other factors. And so how do you get better sleep even with these factors going on? Well, let's move into my particular, one more thing. This was, again, a somewhat smaller study, about 55 people. It was done in Australia and New Zealand, so it may not apply so much to the US, but they were looking at how commonly sleep problems are screened for and treated in palliative care settings, and they found that at least verbal screening of sleep symptoms, very common. More than 70% of providers were screening verbally for sleep problems, and they were recommending some behavioral strategies. More than 90% of providers, palliative care providers, were recommending some sort of behavioral strategy. Most often sleep hygiene, mindfulness meditation, melatonin medication. Evidence-based treatment, assessment and treatment of sleep problems in palliative care may be less common. So using these validated patient-reported sleep outcome measures like the Insomnia Severity Index or the Pittsburgh Sleep Quality Index, not frequently used. Specialized sleep interventions like cognitive behavioral therapy for insomnia or CBTI, not typically used. Access to sleep specialists limited. Personally, and you can correct me if I'm wrong, but personally I think the fact that these evidence-based measures or evidence-based treatments aren't used doesn't reflect a lack of desire on anyone's part. It reflects a lack of time, a lack of knowledge, and the fact that there are a lot of other things that need to take priority, having nothing to do with sleep. So I don't really see this. I wasn't so concerned when reading this because I think the population palliative care is just so medically complex and psychiatrically complex that sleep often has to take a back seat. Okay, let's get into my particular way of thinking about sleep. I encourage everyone, whether you're a colleague, a fellow, a patient, to think about sleep from the perspective of these three systems. One, your circadian clock. So we've all got a circadian timing system, a master pacemaker in our brain and the suprachiasmatic nucleus, which helps determine the timing of not just our sleep-wake rhythm, but our feeding-fasting rhythm, our rest-activity rhythm. And what you want to be doing, if you're optimizing your circadian clock for sleep, you want to be sleeping in a window that works with your body clock. We'll talk about that a bit later. So you want to be sleeping at the right time for your body clock. You want to be keeping a relatively consistent sleep schedule, especially the morning rise time. And you want to be using light strategically. So light in the morning is great, light at night, not so great. You also want to be lining up your major circadian rhythms, like your feeding-fasting rhythm, with your sleep-wake rhythm. So that's circadian system. Now your sleep drive, a biological drive that builds as you're awake and active and comes down as you sleep, you want to make sure that sleep drive is high, that sleep pressure is high when you get to bedtime. And you do that by being awake and active, by not napping too long, not dozing too late. So you want to optimize your sleep drive or maximize your sleep drive. And finally, you want to reduce any hyperarousal. Insomnia itself is often described as a 24-hour disorder of hyperarousal because people with insomnia do seem to be more activated, not just at night, but also during the day. You see higher levels of cortisol, sympathetic nervous system reactivity during the day. You see higher frequency brain activity at night, greater brain and whole body metabolism. Now, the reality for all of us is, if you think about hyperarousal as a stress response, stress disrupts sleep. That's its role. It's supposed to wake you up because presumably you're confronting some sort of threat and you need to be awake to deal with it. You can think of that as the gift of extra time. Now, that is not always helpful if the stress is chronic, because if you're chronically under stress, it can be harder to sleep. And so part of getting better sleep is managing this hyperarousal, managing this stress, because stress will interfere with sleep. But these are the three systems that we can tap into to optimize sleep. I do like to highlight, none of these three systems guarantee sleep, because literally the only thing that guarantees sleep is staying awake long enough. But if these three things are optimized, it's more likely good sleep can happen. So let's start in the morning of our 24 hours. I kept the recommendations very brief. Keep the same wake time. Get up promptly. Get light. Move around. Eat something. That's it. That's an optimal morning routine. Now, what are we targeting? Which of those three systems are we targeting? The circadian system, your sleep drive, or hyperarousal? This is all the circadian system. So keep the same wake time. What you're trying to do when you keep the same wake time is establish a robust sleep-wake rhythm. And the morning time is the best time to do that. That is when our body clock resyncs to our 24-hour environment. Most of us have a body clock that's not quite 24 hours, so most of us a little longer, some a little shorter than 24 hours, but our environment, 24 hours. And so every morning we wake up and resync our body clock to our environment. And morning light is especially how we do that. Keeping the same time helps teach our brain and body that this is the time we need to be up and be alert. And it becomes easier as we do that over time. I don't know if any of you have had the experience of using an alarm for long enough until all of a sudden you're waking up slightly before the alarm goes off. That means you've established a good circadian sleep-wake rhythm. So keep the same wake time, get up promptly. Now, it's very common for people to feel a little groggy when they wake up. They linger in bed a bit, waiting for the grogginess to dissipate. I hate to break it to you, but that is normal. Morning grogginess is normal, in part because melatonin is still in our system. And when melatonin is in our system, we feel low energy, low mood. So lingering in bed actually doesn't make it better, it makes it worse. The grogginess continues. It's only getting up and moving around, getting light, eating something that starts to get rid of this melatonin. So if we look at this, what you're trying to do here, so the gray is the sleep time, and of course, here on the right of this sleep time is your morning, here on the left of the sleep time is your evening. The blue is your melatonin, so you can see melatonin going up in the evening, and it's supposed to be coming down in the morning. And then you can see your body temperature, which comes down in the evening, goes up in the morning, and your cortisol, which comes down in the evening, goes up in the morning. So what you're trying to do, you're trying to, with those instructions I gave you, get up promptly, get light, move around, eat something, you are trying to get your melatonin to come down and your body temperature and cortisol to go up. And light, movement, and food does all of that. So light is probably the most effective way to suppress melatonin. We'll talk about how to get light, because you do have to be creative when it comes to your population. But light is the most effective way to suppress melatonin. So that's the first thing you want to get. Movement, now you don't have to go out and run 5 miles. You can just sit up in bed. You can stand up. You can do some gentle stretching in bed. It's all movement. Movement itself is also going to help to suppress melatonin, but more importantly, increase body temperature and increase cortisol. And finally, when you eat something, even if it's small, you increase your body temperature as well. So light, movement, and food do all the things that we want happening in the morning. Suppress melatonin, increase body temperature and cortisol. The other advantage to having something to eat within about an hour or so of waking up, I mentioned we have this master pacemaker, the suprachiasmatic nucleus, that regulates the timing of our sleep-wake cycle. However, there are clock genes in every cell, tissue, and organ system in our body. And some clock genes in organs like the liver and the stomach are more sensitive to food cues. So if you wake up at one time and you don't eat until hours later, you're actually in a state of internal circadian misalignment, which is why you want to line up your first and last meals appropriately with your sleep-wake rhythm. So the general rule of thumb, have something to eat within about an hour or so of waking up, finish your final meal 3 to 4 hours before bedtime. So light, movement, and food, get light, move around, eat something. This is all in the service of optimizing your circadian morning rhythm. Keeping a consistent rise time does that as well. Now I mentioned light. Oh, well, this is actually a nice little acronym for morning routine, the RISEUP routine. Refrain from snoozing. Again, if you hit the snooze button, all you're going to do is prolong that morning grogginess, or what is called sleep inertia. It's not going to help you get rid of it. Better to just get up, get light movement and food. So refrain from snoozing, increase your activity. During that first hour, you can shower, or if that's too hard, you can actually just splash a bit of cold water on your hands and face. That can also increase core body temperature. Expose yourself to, it says sunlight here, really it's daylight. We'll talk in a moment about how to get this light because it's not always possible to go outside. Listening to upbeat music, something cheerful, can actually help us wake up a little more enjoyably than listening to a blaring alarm. And social activity also helps us feel more alert. So phoning, talking, or texting, friend, family member can help to increase morning alertness. Light itself, again, you can't always go directly outside. The reality is we are most responsive to outdoor light. Doesn't have to be sunlight, just the sun is up even on a cloudy day, we're still getting light. Outdoor light is magnitudes of order more powerful than the indoor light. However, like I said, it's not always possible to go outside. Light through a window, still better. Waking up, sitting up, looking at the window, looking at the outdoor light outside the window, that can be a nice start to a morning routine. You can get light boxes. You can see these two on the right-hand side here. Light boxes are a little different than your average indoor light. These are designed to give you a much more intense, broad spectrum white light. So indoor light intensity is about 300 to 500 lux. These light boxes and outdoor morning light are about 10,000 lux. So a lot stronger. And then there are also these various glasses, IO, Luminet. I don't know what the black one is. I haven't seen that version yet, where this is more convenient for moving around. You can wear these when you're moving around. The light is coming from above, which is actually what you want when you're trying to set that circadian morning rhythm. Because if you think about it from an evolutionary perspective, we're from a circadian evolutionary perspective, we're most responsive to morning light and evening light, the change in light, which means we're getting light from the rising or setting sun. So it's coming down at our visual system from an angle from above. The most light-sensitive cells in the retina are in the lower half of the retina. So you do want light coming from above, which will happen with the glasses, which will happen with higher windows, which will happen with being outdoors, and which can happen with some of these light therapy boxes if they're either on a stand or you put them above. The convenient thing about the light therapy boxes, you can literally put them on your nightstand. And so when you wake up, you can just turn them on and sit up. And right there, you've got some light and you've got some movement. So again, with your population, you've got to be creative. I'm sure some of you are already doing this or have thought of this. But the challenge, of course, the folks you work with are not necessarily going to be jumping out of bed, ready to go. So you need to come up with something that fits, that meets them where they're at. Okay, so we talked about the morning, keep the same wake time, get up promptly, get light, move around, eat something. What about the evening? Exactly the opposite. Keep the same bedtime, avoid light, especially screens, do quiet, relaxing activities, eat early. Keep the same bedtime, of course. We are reinforcing that robust circadian sleep-wake rhythm. I will say, I mentioned it earlier, the most important part of this is the morning rise time. You can force yourself to wake up. You cannot force yourself to sleep. And if you keep that morning rise time consistent, that is one of the things that keeps sleep on track. People get in trouble because if they have a poor night of sleep, they try to sleep in. Now they're getting up later and they're messing up their circadian rhythm. And they're not, interestingly, the moment you get up or sit up, you start building sleep drive as well. So if you're getting up later, not only have you messed with your circadian morning rhythm, but you also are building less sleep drive. So that can delay your bedtime further the coming night, which then delays your rise time. And so things start to get off track that way. Whereas if you get up at the same time every morning, no matter how you slept, that your sleep drive will be higher that night. If you or I had a poor night of sleep and we still get up at the same time, our sleep drive is going to be higher for the next night, which means we'll be feeling sleepy at our bedtime. So keeping the same rise time, most important, but you want to keep roughly the same bedtime. You want to go to bed when you're sleepy, but let's say your usual bedtime is 11. If you're feeling sleepy at 9, you don't really want to go to bed at 9 unless you really have been significantly sleep deprived the night before. You had to stay up late to do a talk. So you want to keep the same bedtime, but with some flexibility. You want to go to bed when you're sleepy. So I could, if my usual bedtime is 11, I could go to bed between 10:30, 11:30 without messing up my circadian rhythm. But if I'm going to bed between 9 and 11:30, that is going to make it harder for me to establish circadian rhythm. Light, I already mentioned, is our most powerful alerting cue. So getting in the morning is great. Getting in the evening, not so good. Screens are especially problematic, especially the ones like your phones or your tablets that are closer to your visual system, to your retina, because they have amplified blue light. And blue light is the wavelength that is most alerting. We have specialized retinal cells that are sensitive to blue-green light, and so they really lock into those screens. And the screens, as we all know, can keep us awake and surfing and scrolling for hours. We want to do quiet, relaxing activities rather than busy activities. And eating early, I mentioned finishing your final meal 3 to 4 hours before bedtime. Why do I say that? Because your melatonin is supposed to go up an hour and a half, 2 hours before your bedtime. Melatonin slows our metabolism. It's also the reason you don't want to eat until about an hour after you've woken up, because melatonin is still coming out of your system. So melatonin slows your metabolism. You want to make sure at least the initial phase of digestion is finished before you go to sleep. That usually takes a couple of hours for it to kind of move out of the stomach. This may be especially important for folks you work with who have GI distress or GI discomfort. And so you want to, if melatonin is going up hour and a half, 2 hours before your bedtime, you want to finish that final meal 2 hours before that, then we're talking 3.5, 4 hours before bedtime. Again, what we're doing here is we're looking at this left side of the sleep window where we want our melatonin going up and our body temperature and cortisol coming down. That is what helps us prepare for sleep. If we're on our screens, literally none of this is happening. And honestly, I think it has less to do with the light, because people can wear blue light blockers, but it has more to do with the content. And although cortisol, certainly some of the content nowadays, can be especially activating, sometimes we're doing things we enjoy that are exciting, but they're still stimulating, which means our body temperature and cortisol are not going to come down. Our dopamine isn't going to come down, and dopamine is definitely an alerting hormone. So the instructions for what to do at night: quiet, relaxing activities, avoid light, especially screens that you're keeping close to your eyes. It's all in the service of making sure from a circadian perspective that what we want to happen is actually happening. I will say TV is the least offensive of the screens, in part because it is far enough away so that the effect is mitigated, the activating effect is mitigated. I will also say that the effect of light in the evening on melatonin, there's definitely studies showing screens suppress and delay melatonin, and in fact, any sort of light suppresses and delays melatonin. When they've looked at hunter-gatherer tribes along the Amazon, some of whom got electricity earlier than others, the moment the tribe got electricity, bedtime was delayed and total sleep time was reduced. So it's not just screens, it's any sort of light. Light was probably both the best and the worst of inventions. So you do want to manage light appropriately, but especially the screens. However, like I said, TV, I think, is acceptable. It's hard nowadays for people to be off screens. There are a lot of potential advantages to, or convenience, I should say, to it. This is an example of a wind-down routine. So reading or listening, reading a book, listening to an audiobook, watching a light TV show. You want to be very careful about the content. Watching politics. I can't tell you how many people watch the news before bedtime. Let me just say it's a bad idea. That is not the way to wind down and relax into sleep. You can get a puzzle or a coloring book, play a game of cards with an actual deck of cards, listen to relaxing music, phone talk or text a friend. Now listen, when it comes to social interaction, I always tell people the way we fall asleep most easily, whether you're 8 years old or 88 years old, is when we feel safe and comfortable and relaxed and loved. And so any conversation you have with family members or friends should embody that principle. There should not be stressful family discussions in the hour or two before bedtime. Family members will have to be educated about that. I can't even begin to imagine how stressful it is for everyone, not just the person who's dealing with the the medical condition that puts them in palliative care, but also for the family members who are concerned about that person. So both patient and family will have to be educated about this. Nice opportunity to potentially introduce some other ways of interacting, but these are some options to include in a relatively screen-free wind-down routine. So we've got morning, we've got evening. What about the daytime? Daytime, get more light. Be more active, physically, socially, mentally. Limit napping or dozing to 30 minutes or less. Make sure it's 7 to 9 hours before your bedtime. What's interesting is the morning and evening routines. I mentioned that from an evolutionary perspective, this is all about the circadian system, establishing a consistent sleep-wake schedule, making sure you're allowing melatonin to go up in the evening, down in the morning, allowing body temperature and cortisol to go down in the evening, up in the morning. That is all circadian. Eating something at appropriate times, all circadian. Daytime is about this interaction between your sleep drive and your circadian system. So this homeostatic sleep drive, like I mentioned, this is the biological drive that builds as we're awake and active, and then comes down as we sleep. And the more you can maximize this sleep drive, the sleep pressure, the better for your sleep. Faster you'll fall asleep, faster you'll get back to sleep. I do want to mention, just as a way to normalize what actual adult sleep looks like, on average, adults wake up 10 to 12 times a night. So this whole idea, I see so many people who come in and tell me they want 8 hours of sleep without waking up at night, and they're in their 50s or 60s, and I literally will say to them, I can't help you. Like, that is an unrealistic expectation of sleep. On average, we wake up 10 to 12 times a night. We don't, if we're awake for less than 3 minutes, we won't remember. So we only remember 0 or 1 or 2 or 3. Any adult who tells you they slept through the night did not. Now, why is that? Well, if you think about it from an evolutionary perspective, sleep is risky. It is dangerous to be unaware of our environment for hours at a time. So we evolved this pattern of waking up briefly, scanning our environment to make sure we were safe. If we were safe, we could fall back asleep quickly. But if we weren't, if we were under threat, we could wake up quickly and do what we needed to do. It is not always a good thing to sleep through the night. If there's a fire, there's an emergency with your child, you do not want to be asleep. So waking up at night is normal. What wakes us up is not what keeps us up. We'll talk about strategies for addressing that. But one of the ways to address it is to build your sleep drive. If your sleep drive is high enough, you will have less wakefulness at night. Now, how do you build your sleep drive? Physical activity, social activity, light exposure. And remember, we talked about some of the correlates of disturbed sleep at night from that study. And one of the correlates was lower exposure to light over 24 hours. So more disturbed sleep is associated with less light exposure. So the more light exposure actually, especially outdoor light exposure, increases serotonin levels. And serotonin is one of the precursors to melatonin. So if you're building serotonin, you're actually increasing the amount of melatonin in your system. So physical activity, social activity, mental activity, outdoor light exposure, all of these help build your sleep drive. So even if you can't be vigorously active, you can still do some things. Maybe walk around the room, stand up, sit up. It's better to sit up in bed than lie down in bed. That will build more sleep drive. Getting light, leaving that light box on during the day, not just in the morning, can also help. The other aspect of these ways to build sleep drive is these are actually part of the circadian wake drive. So if you think about it, our sleep drive is building across the day. So literally we're all getting sleepier. And yet we're not falling asleep. Why not? Because the circadian wake drive sends out alerting cues to keep us awake. What are these alerting cues? Physical activity, social activity, mental activity, light exposure. So the beautiful thing about these circadian wake drive is they dovetail with this sleep drive. The more you can build in these circadian alerting cues, the more likely you are to stay awake during the day, and the higher your sleep drive will be at night. So that's what we're looking at here, this interaction, this tandem interaction between the buildup of sleep drive and the increase in circadian alerting cues to keep us awake even as sleep pressure builds. Now, there is a little dip. You can see it here. I've removed, they used to have the time on the bottom. clock time. I've removed it. We'll talk about why in a moment, but that is because people's sleep timing and wake timing varies. And so you don't want to get caught up in this idea that everyone should be in bed at 10 p.m. and awake at 6 a.m. That is not helpful and not accurate for some people. So I've removed the clock timing, but at some point in the afternoon, sometime between 12 p.m. and 6 p.m., there is a drop in the alerting cues. There's a drop in our body temperature, which actually is associated with sleepiness. So it's actually a good time to take a nap if someone is going to take a nap. The advantage to that is if someone's taking a nap in the afternoon, it's usually at least 7 to 9 hours before bedtime. And that allows people to build up more sleep drive when they wake up. The other thing you want to keep in mind, as I mentioned, you want to keep your naps to 30 minutes or less, because if it's 30 minutes or less, you're less likely to go into deep sleep. And deep sleep is what will interfere with sleep the coming night. There's a caveat to this because, as I mentioned, it's the physical symptoms that seem to be associated with disturbed sleep more than the psychological symptoms. And when I say psychological symptoms, I literally mean anxiety about sleep. Sure, for folks in palliative care dealing with end-of-life issues, there is understandably increased anxiety and depression, but it's not about sleep. It's about other things. And so the hallmark of insomnia, anxiety about sleep, is absent. Misconceptions about sleep are absent because, honestly, end-of-life issues are far more compelling than anxiety about sleep. So at the same time, even if someone has anxiety or depression, if you're building their sleep drive, if you build it enough, if I kept someone awake for 3 nights, I don't care how anxious they are. They're going to be falling asleep. And so you can use this higher sleep drive along with these circadian cues to keep people awake to overcome some of the anxiety and depression. However, because it's the physical symptoms more than the psychological symptoms, the anxiety about sleep, that keep people awake at night, that disrupt their sleep, they are losing some sleep at night. That is the reality. And so even though normally I'd say keep the nap to 30 minutes or less, I might stretch it to an hour, maybe even an hour and a half, depending on how disrupted sleep was at night, with the idea that they will be able to make up some sleep without necessarily interfering with sleep the coming night. Now, this is going to be an individual experiment. And the reality for everyone, not just folks in palliative care, but literally everyone I see, is everyone is different. And so, and because there aren't clear guidelines for how to, well, there's never one size fits all recommendations for people. So there's always a bit of experimentation. Depending on how fatigued, depressed someone is, if they're not too fatigued, not too depressed, you might be able to enlist them with this curiosity about experimenting, seeing what works for them best. But it would require some experimentation with how long the nap is, when they take it, to figure out what is optimal for them. I think the other challenge with this population is there is a distinction between being sleepy and being tired. So, just checking the time. So, being sleepy is literally the propensity to fall asleep, meaning the usual, well, how do you know when you're sleepy? Eyes get heavy. You might start to yawn, breathing might slow, you might do the head bob. So these are all signs of sleepiness. And the usual cause, people have been awake long enough to build up enough sleep drive so that they could fall asleep. Sometimes it's sedating medications, and this is particularly true for folks in palliative care who have increased levels of pain, maybe on opioids. Opioids definitely increase daytime sleepiness, which is a problem. But oftentimes it just reflects this higher sleep drive. Now, fatigue is different. Fatigue is that feeling of physical or mental exhaustion that doesn't improve with rest. The challenge with fatigue is there's so many reasons other than sleep that contribute to fatigue. Getting too much or too little activity, whether physical, social, mental, being stressed, anxious, depressed, in pain, being bored, straining your eyes by looking at screens all day, Alcohol and caffeine, probably not so much an issue, I'm thinking, in your population, but you can correct me later if I'm wrong. Low hormone or vitamin levels, that might be an issue depending on GI symptoms, depending on hormone therapy for the cancer or something else. Circadian effects, if people are sleeping or waking in a window that does not fit their body clock, they will experience more fatigue. Certain infections, medical psychiatric conditions, medication side effects. There's so many reasons that people can feel tired that have nothing to do with sleep. And you want to be clear about this distinction, because if someone is tired rather than just sleepy, the answer is not to lie down to take a nap. The answer may be to rest while listening to a meditation. It may be to talk to a friend or family member with whom they feel comfortable, because that is an energy generating activity. Again, it depends. It can also be exhausting, so you want to be careful about how much time you allow people, or how much time you determine with your patient would be activating, energizing. But you do want to have this distinction clear, because you're going to do different things depending on whether someone is genuinely sleepy versus fatigued. Okay, so we've done the morning routines, we've done the evening routines to help with sleep, we've done the daytime routines. What do we do about nighttime routines? Well, there's several. You want to protect your sleep environment, and a special challenge in the setting in which folks in palliative care find themselves. You want to sleep with your body clock. You want to set the right sleep opportunity. You want to create cues for sleep versus wake. And you want to remain calm and relaxed if awake, whether it's having trouble falling asleep, being awake during the night. So protect sleep environment. Now, this is really hard, and this probably requires systemic or organizational changes, because you can't turn off electronics and devices. I mean, you need those in this setting. You may or may not be able to adjust the temperature. There are going to be lights. And so how do you block those lights? There are going to be sounds. It will be a noisier environment. So what you're looking to do is figure out ways to block some of this. Earplugs could work. A sound machine, white noise, brown noise, gray noise, pink noise, or nature sounds, waves, wind, rain. Anything that the patient finds soothing, that is going to depend on individual preference, could block these more intrusive noises. The way to think about it, again, intrusive novel noises, your brain is going to orient to as a potential threat, which means at a minimum, there's going to be a micro-arousal. There will be a brief, not a full awakening, but jolting into a lighter stage of sleep, or someone might wake up fully. That's to a novel intrusive noise. But if you have a constant background noise, your brain will learn within a few minutes to tune it out as a possible threat. And then that will potentially mask any intrusive or novel noises. Some people really like earplugs, some people don't. There are various kinds. There's the foam earplugs, silicone earplugs, custom earplugs. Probably the most comfortable and also the most expensive. You want to make sure the bed is comfortable. Again, that can be a challenge. People don't have control over the mattress used. They might, I don't know if they have control over the pillows used. They might have control over the bedding used, but probably not. You can't turn off the electronics, but you might be able to use a sleep mask. I don't know if it's possible to get blackout curtains or if that's allowed. I don't know what the window situation is like in the room. Cooler temperatures, again, we sleep better anywhere from 62 to 68 degrees Fahrenheit, although the full range is 57 to 72 degrees, depending on individual preference. So there are a lot of things one could potentially do to create a more comfortable or sleep-conducive environment, but I don't know how much of this is possible in the setting that these patients find themselves in. Sleep according to your body clock. Sleep with your body clock. There is normal variability in sleep timing and sleep need. This is partly genetic, 40 to 50% genetic. There are larks and hummingbirds and owls. Most people, 65% are hummingbirds. Those who naturally feel sleepy at 10 or 11, naturally awake at 6 or 7. Then you got your morning larks who are sleepy usually around 6 to 8 p.m., but awake at 2 to 4 a.m. And then you got your night owls who are sleepy sometime after midnight. Most common bedtime 1 to 2 a.m., most common rise time 9 to 10 a.m. All normal sleep. as I said, this is 50% genetic, which also means it's 50% behavioral. So the behaviors people choose to engage in, especially before bedtime, can further delay their bedtime. But it is a good idea to just ask your patient, if you've been on vacation or you've been retired, when do you normally find yourself going to sleep and waking up? Someone might get into bed at 10 and not fall asleep for 3 hours, which means their bedtime is 1 a.m. And then they could sleep until 8 a.m. But maybe they have to be up at 6 a.m. for work. So you want to be careful to find out. Usually the best way to ask is when you've been able to sleep, like go to bed when you actually felt sleepy and wake up when you actually felt ready to wake up. What did that look like? What was the timing of that? And that'll give you a better idea of whether someone's more morning or evening. You're safe enough starting with this neutral sleep phase, but then depending on whether someone's having trouble falling asleep, waking up. So let's say you start out with an 11 to 7 sleep window, but the person has trouble falling asleep and they have trouble waking up. That tells you they're probably a little bit more delayed. So maybe you move their bedtime to midnight. So maybe now it's midnight to 8 a.m. But what happens if they're having trouble staying up until 11 a.m.? 11 p.m. Well, that probably means they might be a bit more of a morning type, and so maybe now you move the bedtime to 10 p.m. or maybe 9 p.m., and then their wake time is earlier. So you can experiment with this depending on patient preference. I will say we are more of a morning culture here. Cultures in Spain, Morocco are more evening. And so there can be an internal stigma about acknowledging that someone's more evening. I've seen this a lot, where someone who turns out to be an evening type, bedtime 1 a.m., wake time 8:30 a.m., will say they're a morning person. They turn out not to be a morning person. So you have to be aware of that nuance, that internalized negativity toward being more of a late night person. So you want to see if you can help the person identify what the optimal timing of their sleep window is. You want to identify the optimal duration of their sleep window. This is especially challenging because everyone, like the media, is just telling everyone they need to get 8 hours of sleep. This is not accurate. This is not helpful. Sleep need differs between people. It's 40% genetic. It changes with age. We get less total sleep as we get older. This is a chart put up by the National Sleep Foundation. It purports to show recommended sleep time across the lifespan from newborns on the left to individuals 65 and older on the right. This is not 100% accurate because even though it was put together by consensus of sleep experts who reviewed hundreds of studies, almost every study relied on retrospective self-report of sleep, which is notoriously inaccurate. The way I prefer to talk about this is recommended time in bed with the expectation that most of that time, 85 to 95% of the time, you're going to be asleep. So if we were to take the largest age group, 26 to 64, the range of normal time in bed to get the appropriate amount of sleep is 6 to 10 hours. That is a big range. On average, the dark blue rectangle in the center, these are the average sleepers, the ones who need to spend 7 to 9 hours in bed to get the right amount of sleep, so you're pretty safe starting there. Then you got the short sleepers, the ones who need to spend 6 hours in bed to get the right amount of sleep, and then the long sleepers, the ones who need to spend 10 hours in bed to get the right amount of sleep. All normal sleep, like I said, 40% genetic. Again, a bit of a challenge because people, it does seem as though, especially with end of life, sleep time, total sleep time, not just at night but during the day, can increase. And so this sort of goes against the grain here, against the normal progression, which would be less total sleep time as we age. But you want to ideally figure out the right sleep opportunity for the person, because otherwise if people spend more time in bed than they can fill with sleep, they're going to be awake during the night and they are going to reduce their sleep drive, which is going to fragment their sleep. It's going to make their sleep worse. You also want to create, this is especially important because, of course, folks on palliative care spending a lot of time in bed, but you want to create a clear set of cues for when they're going to be asleep and another set of cues for when they're going to be awake. For example, when they're going to be asleep, they're lying down on one side of the bed, depending on how wide the bed is. They are using Warm, yellow or red light, quiet, soothing sounds, cooler temperature, comfortable bedding and pillows. They might use a sleep mask, earplugs. When they plan to be awake, they don't intend to sleep. They're sitting up. They're either out of bed or on the other side of the bed, again, depending. They could flip around, put their head at the foot side of the bed and their feet at the head side of the bed. You want cool white or blue light, the more stimulating light, louder, more upbeat sounds, warmer temperature. Of course, bedding and pillows should still be comfortable, but accessories are daytime activities. Maybe they're looking at their phone, their iPad, watching TV, reading a book. They're doing things. So this is important because the brain will learn consciously and unconsciously to associate this one set of cues with being asleep and the other set of cues with being awake. And we forget we're animals. We can be trained like a dog or a rat. If every time we are doing this one set of things, we are sleepy or sleeping, our brain is going to learn, oh yeah, this is when he or she is going to sleep. Let's help them feel sleepy. If this other set of cues, every time we're doing it, we are doing something wakeful, brain will learn, oh yeah, this is when he or she is supposed to be awake. Let's help them feel more alert. So this is a very powerful technique. Challenging because it's across the 24-hour period, but it can be really, really helpful for sleep. Now, finally, this sympathetic to parasympathetic shift. In order for sleep to happen, we have to shift from a sympathetic stress state, which we're all in to a greater or lesser degree when we're awake. That's the reality of being awake, the cost of being awake. We have to shift from a sympathetic to a parasympathetic state, that rest and digest system, because that is a state we are in naturally when we sleep. And the more we can facilitate that transition before or immediately after we get into bed, the better for our sleep. How do we do this? Distraction, one-way relaxation, mindfulness, self-compassion, faith, spiritual practice. I should also mention, even though I'm emphasizing this shift in the evening or immediately at bedtime, the reality is if you manage stress effectively during the day, if you shift back and forth between sympathetic and parasympathetic during the day, your stress level at night will not be as high. So this is also a 24-hour endeavor. I'm sure you all have plenty of resources for this. These are just some of the ones I really like. So relaxation, you can use breathing, paced breathing, so extended exhalation, diaphragmatic breathing, progressive muscle relaxation, positive visualization, body scan. Insight Timer is one of my favorite apps because there is a free version which has the largest library of guided meditations, different voices, different pacing. Some have music, and I have learned everyone is different. Some of the people I love, others hate. And vice versa. And so you want to give people lots of options so they can find something they like. You can bookmark your favorites, find them very easily. For mindfulness, there are different components. There's compassion toward others when they suffer, loving kindness, the desire to see them happy, gratitude, being grateful for the many things, many positive things in life, empathic joy with others. These are some of the resources I use, some apps, Calm, 10% Happier, Headspace. And then University of California, San Diego, and University of California, LA, the Mindful Awareness Research Center has a lot of free guided meditations. Calm, 10% Happier, and Headspace are subscription apps, so they're not, you do have to pay. UCSD and UCLA are free, which I really like. Then there's Self-Compassion, developed by Kristen Neff and Christopher Germer. I've got their websites here. Also the Center for Mindful Self-Compassion. It includes not just mindfulness, but self-kindness. So not just kindness toward others, kindness toward ourselves because we are suffering, because we are struggling. And then a connection with common humanity because the thing we all share in common is suffering. That is the common core of humanity. And finally, faith, spiritual practice, religious practice, contemplative practice. Obviously, I didn't put any particular signifiers for a particular faith or spiritual practice because everyone has their own version of it. These are a couple of articles. Interestingly, this is an online sleep education intervention called PRIME for the program for improving the management and environment for sleep. It was a small study that talked about the development of the content and the design for this program, then showed this program to focus groups, about 30 nurse practitioners, to get their feedback on acceptability, feasibility, satisfaction, largely good ratings. These are just some of the areas that they included in the education, which I thought really fit. So some sleep basics, some basic understanding about normal variability in sleep timing and sleep need, the importance of shifting to that sympathetic state before bedtime. Screening and assessment, we talked about how that might be a bit more limited than some of us might like or some of us have time for. Relationship between sleep and dementia, sleep and cancer, and then various interventions, both pharmacological and behavioral, that's the sleep hygiene, importance of sleep environment, and then complementary and alternative practices. And then there was another study that pulled together focus groups, about 32 people in total, all working in end-of-life settings, 4 different settings, 3 different areas in New York State. And these are some of the interventions that they talked about. I'm not going to go into it in detail because I want to make sure we have time for questions. I won't go into medications, although that is an important part, especially with this population. If you want validated sleep assessments, not just insomnia, but other sleep disorders, here's some good ones. The sleep disorder scale checklist, 25 items. This is probably the most thorough as far as evaluating all sleep disorders, and then the Pittsburgh Sleep Quality Index. A little shorter, more widely used, but I don't think it gets at sleep disorders as effectively.